experience in the United Nations Industrial Development Organization, Vienna, Austria, where he served in various capacities. He has authored several books and journal articles on the changing patterns of development, focusing on the key determinants on economic efficiency, ecological compliance, and social inclusion. His most recent works include Myths and Realities of East Asian Model of Development, India's Time, Rethinking Development Realities, and Intervene to Industrialize. He has won several awards, including Dynamic Indian of the Millennium Award, and recently Auckland-based Indo-New Zealand Business Association gave him a commemorative award for his distinguished contribution to the international community. And he received Lifetime Achievement Award from Bharatadasan University in the year 2019. Though he is busy with his professional life, he never turns down our invitation when it comes to sharing his wisdom. A man of mastermind and a renowned economist in the world. Ladies and gentlemen, please join me in giving a warm welcome to Dr. Jebamalai to deliver the keynote address. Over to you, sir.
Thank you. Esteemed Vice Chancellor, Dr. Vijayaraghavan, distinguished panelists, and dear participants, I would like to express my profound sense of gratitude for the kind invitation from one of the prestigious institutions in India. I feel honored. Intellectual honesty tells me that I am not technically qualified to participate in this event, that too in the capacity of the chief guest of this seminar, because I am not a medical doctor. So when I received the invitation from my good friend, Dr. Selvam Jesaya, I was reflecting on the topic. I suggested that I would like to speak on the current digital transformative shift in healthcare leadership. I held substantive technical sittings with Professor Moni Madasamy, former Director General of the Informatics Center, Government of India, and I gained a lot of ideas from him. I have incorporated, so I would like to give part of the credit of my presentation, large part of the credit to him. He is actually participating. He just told me, he sent a message saying that the participants are not able to hear. I don't know if there is a technical snag, kindly rectify it. I forwarded the message to Madam Purnima. Can I request you to just present my PPT?
Yes,
Madam Rohini? Okay.
Yes, sir. Yes.
Excellent. Okay, you can go to the next slide actually. Yeah, okay. Let me begin with cleaning the definitional ambiguities related to the current digital transformative shift in healthcare management. Let me read out what the real definition given. Digital health means artificial intelligence and machine learning based on platforms that aggregate patient data for apt intervention. I find a serious flaw in the definition. I think they should add the word smart mission before the word mission, smart mission. And they should also add one or two words at the end of the definition. Apt intervention for what? As things stand today, apt intervention only for curative interventions. Everything is curative intervention centric and does not say one word about preventive interventions. I think as an economist, this is what I find. I think the definition is not adequate. Now look at the various aspects, facets of the so-called health informatics. I think what is contained in the slide is self-explanatory. I don't have to read out. I am not able to find one word or one phrase related to preventive interventions. Again, a giant disappointment to me. As a patient, I am just looking at it as a patient. So all these domains are curative intervention centric. They do not address the root cause of the diseases. True healthcare leadership should encompass preventive interventions also. Please go to the next one, madam. Next slide. Yeah. If you look at the history of economic development, rapid, revolutionary, and complete changes were triggered by technological marvels. The incidence of technical progress went deep into each and every aspect of producing, processing, and marketing products. This is what we learned. First, second, third industrial revolutions were triggered by fast changes, triggered largely by technological marvels. And today we talk about the Industry 4.0. Industry 4.0 is underpinned by disruptive technologies. These disruptive technologies are actually pushing us to the state of creative destruction. We are living in an era of creative destruction. New changes make old things stumble, and every time we have to be tuned to the rapidly changing facets of whatever we do. Disruptive technologies are advanced digital production systems, artificial intelligence, augmented reality, then additive manufacturing, big data management, cloud computing, then 3D printers, electromobility, Internet of Things, Internet of Services, Internet of Energy, and even now talk about MindNet, which is very dangerous, to be honest. MindNet. So, in an era of disruptive technologies, we are facing what is called a disruptive, creative destruction. Now we just move to Industry 5.0. That's very narrow definition. We are all conditioned to work hereafter. What is the future of the workforce? Recently, the World Economic Forum published a document on that. Ford Foundation published one on the same subject. I went through the two reports. The real summary, it can be summarized in one sentence. We are all conditioned to work with, we will be soon conditioned to work with smart machine, robots, and artificial intelligence. So health sector is no exception to this trend. I would like to spend 1 minute on the difference between digitization and digitalization. Digitization entails storing data in digital form, pertinent data related to anything. As an economist, I would like to store data in digital form on data related to new and dynamic sources of growth. I am sure it is applicable to health sector also. And then digitalization means you just use the digitized data for effecting improvements. And then the primacy of digitizing and digitalization in effective health leadership could be understood in different ways. Please go to the next one. Yeah. What is expected of any institution dealing with the health sector? The minimum is to create an inventory analysis of the frontiers of best practice in using digital technology and devices in medical interventions. I don't know how many institutions do. That's a minimum. That's a starting point. You cannot plan without figures. So once you create that inventory, I said inventory analysis because each hospital is armed with the experts, specialized experts with several years of experience. I used to say experience is the richest institution. You can Google anything except experience. So this talent can be effectively used for analyzing the inventory data related to the frontiers of best practice in whatever you do. And then next one is to see your distance to the frontiers of best practice. You don't have to replicate the best practice within a day or two. Minimum is to know where you stand. what is the distance, and then try to identify viable avenues of reducing the distance to the frontiers of best practice in medical interventions. Please go to the next one. Okay, simple example. MBBS doctors who often serve as general practitioners, for me, they are the nerve center. They constitute the nerve center of the healthcare, because patients normally go to them for their advice, and these people ask them to go to hospitals or start treating them also. So they constitute the nerve center. My question is, do general physicians keep a copy of their prescriptions and proscriptions? A doctor may see 100 patients a day, and he picks up the chit and prescribes and proscribes. Does he keep a copy of that? Are general physicians aware of medication tracker apps? Someone told me that around 35 apps are available. I don't know. I'm not an expert on this. I just checked with somebody casually. He said more than 30 apps are available. Are the general practitioners aware of that? If at all they are aware of it, are they using that to monitor the progress made by the patient? Then what is the percentage of general physicians using medication tracker apps? I think it is meager to the extent of being negligible. This is the ground reality. What is needed is effective knowledge dissemination about the usefulness of all these things. And okay, you can stay here. It's okay. Please go to the next one. So, having said that, I would like to reflect on the key facets of digital health care. They are all very good. Almost accurate diagnosis. It is always believed nothing is 100% in medical science. You make a guesstimate, estimates, and you as doctors, you know that nothing is 100%. But when you use the technological marvels, the digital healthcare system, and highly sophisticated technology, I think it is almost accurate. I was able to say 100% accuracy in diagnosis, but I took the liberty of putting the word almost accurate diagnosis subject to human error. Intelligent digital solutions, again subject to human error. Digital capability enablers and high degree of precision in medical interventions. And what is the outcome? Which is very good, very encouraging. Dramatic increase in survival rate as evidenced by, facts, as evidenced by empirical evidence. Okay, please go to the next one. Next one. But there are issues we cannot afford to ignore. Key issues posing healthcare leadership. How could healthcare leadership make highly sophisticated digital-based diagnosis and treatment within the means of the poorest of the poor? This is the major issue. I'm from Kanyakumari, and Nagarkovil is well known for best medical treatment. A patient goes there with a mild headache or anything, and he's hospitalized. If he's hospitalized for 3 or 4 days, sometimes I have seen families selling their properties, selling the paddy field, selling the coconut plantation, selling the jewels. I used to wonder, what is this? What type of this? One big hospitalization is leading to the very high cost, which is definitely not within the means of the poor people. I think this is, if the healthcare leadership could make the highly sophisticated healthcare treatment based on digital interventions, I think that will be a major contribution to society. And sometimes you go with for mild, the very small problem. I think sometimes in some hospitals they overdo. Immediately they ask the patient to go for this test, that test, and this and that. And after 5 days, a minister told me he was examined for 5 days, and to be told that you are perfectly all right, please go home. And what is the cost? At a very high cost. I have a lot of respect for Indian doctors. Having lived in Vienna for more than 35 years, I really inculcated a lot of respect for Indian doctors, because when an Indian doctor touches the human body, he knows how the whole system operates. I will give you one example. Once I collapsed in the living room. My wife immediately rushed me to the Kaiserin Elizabeth Hospital in Vienna, which is located very near to our house. And the doctors came and they said, "You are from which country?" "India." "Did you go to any tropical, did you go to India recently?" I said, "No." "Did you go to any tropical country?" "Yes, I went to Nigeria." And immediately they said, "You are suffering from malaria." And they already decided. So just for the poorest reason that I went to a tropical country, the decision by the doctors was not. So they sucked, I think, 12 tubes of blood from my body to see whether I am affected by malaria. Series of tests. So my wife came in the afternoon and asked me what is going on. They are suspecting malaria, and they have taken 12 bottles of tubes of small tubes of blood, and they are examining, conducting series of examinations. And there, unless they diagnose something, they will not start the treatment. You know that. Then next day, again, they could not find any trace of malaria. They again took blood, I think 6 bottles, this time it was less. Again conducting further intensive examination to see whether I was suffering from malaria. Third day, when my wife stepped into my room and asked me what is the latest, I told her they are waiting for malaria to come. This was my comment. And this would not happen in India, Within a day, they will find out and they will prescribe something, and on third day or fourth day, you will be on your feet. Now, are we overdoing? This is my concern. I think healthcare leadership address. The next issue is, can health informatics value chain network address the root cause of disease? I am going to elaborate it in the subsequent slides, and I would like to recognize the contribution of Professor Moni Madasamy. Now, can it address the root cause of diseases? We eat unhealthy plants, unhealthy animals, unhealthy fish, we drink unhealthy water and breathe unhealthy air. Is the healthcare leadership attempting to this to address the root cause of the diseases contained in all these things, what I explained now? Then is it possible to use person-centric digital healthcare to decouple patients from doctors and hospitals? I think even WHO is now coming out with a program to decouple patients from doctors and hospitals. Tamil Nadu government's recent announcement, Makkalai Thedi Maruthuvam, is part of it. They don't have to go to the doctor and they don't have to go to the hospital. And given today's technological marvels, when someone suffers from something, using the symptoms, he can Google or use a search engine and see what is it all about. He can even understand the exact magnitude of the problem and also attend to the curative interventions to some extent. I think decoupling the patient and the patients from doctors and hospitals may be a very good initiative. Is it possible to use then how to use digital healthcare to optimize the proven benefits of traditional medical knowledge and practices? In the wake of COVID-19, we are increasingly realizing the importance of traditional medical knowledge, traditional medical practices. Actually, in the sphere of medical healthcare, and we are back to the future, and it is proven to be very, very useful. So, can all these digital healthcare interventions optimize, create a unique blend of both, then responding to the unexpected, as rightly said by the Honorable Vice Chancellor, rapt attention and apt response. This is very, very important. I will just tell you today's situation. I was actually in India. I landed 2 weeks ago in Vienna. I just asked about the problem, a COVID issue here, and they said nothing, hardly 65 in Vienna, in the country, maybe 120. You may not believe today it is 10,000. So you expect the unexpected. and as one of the speakers nicely said, optimize our interventions to accommodate more patients, how to do that. And when suddenly you are pushed to a condition to treat 10,000 patients in a country like Austria, where only 8 million people live. Now it's a big issue, and the system responds very well, very well. They are testing. And I could say amazing response in institute. I think they even reduce the number of outpatients. That's the first thing they do. And then they change the priorities. Very critical cases are attended to, others are postponed. I think the healthcare management leadership is working very well in Austria. And life as usual now. Yesterday, I took my guest to a nice Greek restaurant for dinner. Of course, there are some conditionalities imposed on us. We have to show some certificates and this and that. And with that, life is as usual. So I think our capacity to demonstrate rapt attention and apt response to unexpected developments is very, very critical. Please go to the next one. Next slide, madam. Yeah. The future we want. What is the future we want in healthcare leadership, and particularly in the sphere of the so-called digital transformative shift? Digitalized, integrated health management system, linking human health, plant health, animal health, soil health, fish health, water health, and air quality. This is what is called integrated, digitized, integrated health system. If you concentrate only on curative interventions and completely ignore the preventive interventions needed, I think we will not add to the correctness and completeness of healthcare leadership. Please go to the next one. This I got from Professor Modi Mansan. I very sincerely request Dr. John and Dr. Selvam Jesaya to invite Professor Moni Madasamy, and I discussed it with him, to offer an optional subject covering all these aspects: health informatics network value chain. I think this is very, very important. I am sure many students will prefer to do that. And you look at the components here, the public health system, then plant health system, then animal health system, then fish health system, and then soil health system. And that's also very important, soil health. We believe that all the ingredients contained in the soil are meant by Almighty God to strike a balance in animal metabolism and human metabolism. When the soil is completely ruined, I am sure health-related problems will surface. That's also very important. Water quality system, air quality system. So I think this is the need of the hour. Educating people on health informatics network value chain. It is in the value chain. Value is added to raw materials to earn huge margin. The prosperity is essentially a matter of value addition. If you don't add value, you don't grow. The African countries, take the example of African country, each commodity is a tragedy. Coffee tragedy, tea tragedy, cocoa tragedy, palm oil tragedy. Look at this. Oil palm was originally transplanted from West Africa to Malaysia. In Malaysia, the tree is a potential source of wealth creation. In Africa, it is still a tragedy. And today, Malaysia is establishing palm oil research center in West Africa, from where the plant was originally transplanted. It's a tragedy. So what happened to this particular product? Because in Malaysia, they applied science and technology to each aspect of the efficient farm management to producing around 83 varieties of value-added products, and booming like anything. And that's a principal source of wealth creation in Malaysia. So value addition, but in the value addition, many private sector stakeholders misbehave. When they misbehave, all these health-related problems will come. I think the healthcare leadership cannot afford to ignore this. And next one, madam. Next one. Go to the next one. One nation, one health system by 2030. Okay. the policy of the government of India envisages to integrate modern traditional systems of medicine like allopathy, homeopathy, Ayurveda in medical practice. Last time when I addressed the participants, I made a reference to this, and I quoted one Latin American doctor who said that if allopathy doctor knows only one, his subject, and does not know anything about related subjects like homeopathy, Ayurveda, Siddha, and he does not know his own subject well. This is what he said. I think the government's programmatic accent is on that. So in order to translate this into deeds, what should I do? This is my humble opinion. If you are very serious about it, establish a central university of holistic medicine in each state. Why can't we do that? When I sent the PPT to Dr. Selvam Desaya, he asked me, what is holistic medicine? We never heard of it. I coined it. It may be wrong or right. I think my common sense tells me, if you are serious about it, you should really establish a center, a central university in each state to have a unique blend of all these medical interventions. I call it holistic medicine. It is subject to correction. Then next one. Yeah, this is the last slide I want to see. I want to make a reference to the key message of WHO report on global strategy on digital health by 2020 and 2025. Again, please look at all the words and phrases. Everything is curative, intervention centric. Unfortunately, it does not say. Now, see, 13, like one sentence with commas, with no period, not even a semicolon, with several commas, covering 13 lines, and not even one word related to preventive healthcare intervention. This is what is called the poverty of scientific thinking.